to manipulate those instruments, XCP instruments that we taught in the very first class. And how can you place those XCP instruments? And you do have here anterior XCP usage and posterior ones. And this is for piping. And this is how you're required to submit your competency when you do your last or final rotation. So this is a sample that you have access. So basically when you take an image, here like a sample inside the view, what are the problems with that? That the sensor is parallel or not. So you'll make a comment, and what is the anatomy included, how can you so you do have access to these. It is posted on your canvas. So again, just to let you know one more time, so under the modules, all the way down here, there's something called as lab rotation. This is where you find that information. So now, there is also a component called as radiographic anatomy on your canvas. You should have access to those. So, and again, remember, this is what I'm showing is, this is how to look my side of the campus. For students, it's going to be slightly different. So please make sure that if you don't have access, please either you contact your class president or Rama, because she's taking the notes, so that she can communicate with me. Rather than, if I get like 50 bombarded emails, I may not be able to respond. Okay, one contact person is easier for me, right? Either class president or even vice president is fine with me. So now going back. Again, if you look at my dashboard here, this one. So this is where you will find something called as radiographic anatomy. So if you click on this one, it will pop up. Please make sure that you are using either Chrome or IE, that is Internet Explorer. I don't think it's going to work on Safari or if you're using Apple products, although I love them, but it doesn't work. Our school doesn't not support. And then, relax. Give me relax. Much better, right? So this is how it's going to open up, and basically, if you click on this one, so it's, the question it says is locate the amalgam restoration. Okay. And you do have, move on to the next one, so basically, can you locate the amalgam tab? So if you click, that's where you are going to find. And locate the angle of the mandible. And what is the next question here? Antrolith. We'll go into the details of antroliths when we talk about the interpretation part. Okay. So please review this material. I will not have time to review in the class. So it is your responsibility from here onwards to review this material. And again, my dashboard here. So this is the course that I am teaching, 120. So if you go under the modules, so the very first lecture here, Intraoral Radiographic Anatomy. This, I believe, is not without any sound. So basically, it also explains you how to place the intraoral XCP instruments in the oral cavity and how to apply a radiograph. That's what the video talks about. Yeah. These, starting from 1, 2, 3, even 4, they do have voice, and there's some video. You could look at those things. Again, there's anatomy that I've discussed a little bit, how to look at the full mouth series, and how to look at that. And down the road, as we move along this semester, we'll talk about panoramic radiograph, okay? How the anatomy will look like a little bit. Not so much, I may not have time to dive into deep. Okay. And I got an email from Rama saying that it was a question whether the final will be cumulative or not. The answer is yes, the final will be cumulative. So that means you have to read everything. The second question that I got was the lecture material was not posted, the one that I gave here. So I tried to modify. So if you look at these, they have been changed. So I put those dates so that becomes it's easier for you when I taught that particular lecture. Okay. So every year I try to change something so that it's not boring even for me and for you guys. So there will be few changes, and as I told you guys earlier, in the middle of the night I'll think, okay, maybe this might be helpful for the students, maybe they'll understand better, then I'll take a picture and then put it there. So there may be 1 or 2 changes, very minor, but majority will be the same. So this module, this is how it looks on my side. This has been nicely designed, like here, intraoral radiographic anatomy. That's what we covered on the first day of our lecture. And we did talk about radiation physics, right? And radiation biology a little bit, but we did not have time to finish. So we will revisit that today. And also this, hopefully we'll try to cover everything. As far as the following week's lecture is concerned, here the radiographic technique and anatomy part, that's the only one I'll be discussing. CBCT in dentistry, I will not be discussing the next week, but on February 25th, I do have a session with you guys, with Dr. Landers. So, anatomy. That's where I'm going to cover. So, I don't want to repeat twice, so if there is any pending portion today, so I'll try to cover next week. Okay. Few things that I would like to highlight is this is very, very, very critical and very important. So what I'll try to do today is, rather than going straight into the unfinished portion of radiation biology, we'll take slight deviation. And then we'll try to look at the radiographs, because I think some of your colleagues are coming to the lab. It might be helpful, and since you have to take a midterm exam, it will be helpful for you as well. Okay. So here is the link to radiographic mounting and anatomy. Hopefully, not the anatomy, sorry, the mounting. When I say mounting, it's basically means how can, well, it looks like it does not want to behave. Let's see if it is, I posted on the syllabus as well, so. right? Well, I tried last night, it was working. Well, let me work on this, okay? I'll update you. Mounting basically means how to place radiographs in a series, like starting from 1 to 16 and then 17 to 32, because you could initially get skewed when you are placing those radiographs. How to look at the maxillary teeth, how to look at the mandibular teeth. Okay. Can somebody access with any other computers?
Mine says the same thing, that it can harm your computer and ask if you want to keep or discard. So I think you have to click keep.
You did that.
Okay, let's try that. Keep, okay.
It's working on mine. It was working on mine.
It's working, okay. So can you show it to your friends? Or can I borrow?
Yeah.
Let's see. So basically this is how it's going to look like. So if you click on patient Andrea here, so you get to see a set of radiographs here that are placed at the bottom of the screen. So all you have to do is drag and drop. So for instance, this one is, I know that this is a bite-wing radiograph. I'll try to place here, okay?
You can try using it as a computer.
What's that?
You can try using it like instead of as a tablet.
Okay, since I'm not too familiar, do you want to help me?
Yeah, sure. Here, let me just come up.
Volunteer for the audience.
Oh, the application's being weird on my computer. I don't know how to fix it. It's like freezing.
It's freezing, okay.
Yeah, sorry about that.
I'll look into it and I'll update you guys, okay? In the meantime, not to waste our precious time. See, it's 8:14, oh my gosh. So we'll look at this image quality analysis. So this is a typical full mob series. That's how it looks like. So you're supposed to capture these things. Like for example, this left mandibular view here. Ideally, you should capture the first molar, second, and even the third molar. Occasionally, it may not be possible, but this is perfect one or the ideal one. So when you are looking at the criteria, because you do have to do this criteria not only for your competency in year T1, you have to finish your competency even either in D3 or D4. Otherwise, you cannot graduate. So I'll hold you guys. Okay. So the things that I look, image mounting. What exactly do I mean by image mounting? Is whether the radiographs are appropriately positioned or not. Say for instance, tooth number 1 is positioned on the template correctly. If I see that 32 tooth number has been placed in number 1, I will not even look into other things because that's waste of my time. Because by the time you should know how to mount a full mount series. That's the basic step, right? Otherwise, if you send the same set of radiographs to a different dentist, or maybe to your junior, what if they drill class 2 on that, right? So mounting is critical, and there may be a couple questions on mounting in your midterm exam. So image quality. So what are the things that I look? Density. So you guys are familiar with the density, right? Yes. And then positioning. So do I see all the teeth? Or there were some clinically challenging cases. In those cases, you may not be able to capture the teeth. But at least can I see in a different view? Is it acceptable? Then I would say, okay, fine, clinically it is acceptable. You can pass, yes.
Actually, I don't understand the word density in this context.
Density is basically the amount of black and white that you can see on a radiograph.
So that's like contrast?
Yes.
Okay.
Oh, contrast, again, density is different, contrast is different when you are using in radiology. Contrast is number of grayscales that you are going to see.
Okay.
So for instance, are you an Apple user by any chance?
No.
Okay.
Pretty hard line on that, actually.
Well, then what example could I use? Well, those who are using Apple, they say that retina display, super retina display, all those things. So basically what they're doing is they're putting more and more pixels so that you can get more colors. So similar in our dentistry, when I say contrast, we are talking about a gray color.
Right.
So when I say gray colors, again, when we go, as we move along the course, you'll understand what I mean by gray colors. So typically we see black, white, and gray. There are some shades of gray, depending on the instrument that you use. So at our school, we use 2 to the power of 18. If you multiply that, so many colors of rays, that's what you are going to see. So white is critical, because you want to distinguish between enamel, dentin, pulp, because of the different shades of gray. That's what I mean by contrast.
And all that, I follow, but is density the, like,
Density is flat.
pixels per square inch, or?
Yes, we'll go into the details. For now, density is, can you see clearly or not? Just,
Okay.
we'll go into the details when I talk a little bit about digital dentistry. Because if I talk a little more, I'll lose other students. And is it of a diagnostic value or not? Sometimes, if you diagnose on a non-diagnostic radiograph, you could end up in medical legal problems. Please, if you are in doubt, get in one more radiograph and try to evaluate. Don't look on the non-diagnostic radiograph. Why? Why this performance criteria is really important is because that's where your crux or diagnosis is concerned. Based on that, you are going to treat. So let's take an example. Again, since we are using a digital image, we may not see a lot of difference when you change the time. But if you are going to use film down the road in your practice, or if you are going to use something called as faster plates or PSP plates, then just, if you miss that 0, you could see the difference between 2 images. The top one is noisy image, right? Whereas this is, by changing the time, you are getting a different image. So it is critical that you have to maintain the mentioned time or posted time on that particular chart. Sometimes you may have to change the timings based on the subject contrast. What I mean by that is, if the patient is chubby, then you may have to increase more time. Remember, with the digital, you may, if you are, sorry, if you're going to increase the time, like twice or maybe a little, you may not see a vast majority of difference because there is something called as autocorrection in the digital images. It does automatically. We can't figure out. So that's the downside of using a digital image. With the film, if you use too much of image, the image will be completely black because there is nothing that we can control. With this auto processing, you can control. Okay. So please remember when you are exposing a radiograph, look at the time and then expose. So if you look at this particular image, what is happening here is it is not appropriately positioned, right? If you are trying to capture a lateral, canine view, here canine is missing because the receptor is positioned much more posterior. So you have to make sure that you have to capture the canine, at least distal of the canine, because in other views, you are not going to capture. So the correction that you have to do is bring the sensor more anterior. So here, these are all the examples that I got it from our school. So that means this is the artwork of our dental students. So if you look at here, what is happening is you're not seeing the apices, right? Apical region is missing. So what has happened here is the sensor or the thing has little higher above. Imagine these are your teeth and the sensor is like this. So you have to bring the sensor like this so that you can capture. So you are wasting so much of space here, right? Basically the patient did not bite on the bite block. So that's is one of the reasons you are only capturing the superior most portion of the teeth, not the inferior most. So here is one more example. So in this particular instance, what has happened is the sensor is flipped rather than like this horizontal rectangular thing, it has moved like this, right? So what is the problem with that? You are going to miss the contacts, open contacts. So interproximal contacts, you will not be able to appreciate. So how do you rectify? Just make sure that the sensor is parallel to the occlusal plane or occlusal line. So if you see here, this is a bite bearing radiograph. Again, the patient did not bite properly. So it's like when you ask the patient to close mouth, what they do is most of the time they do like this. They will not bite on their teeth like this, you know. So please make sure that they are biting on that bite block. Otherwise, you are going to miss 3 to 4 millimeters, which we are supposed to capture. So this is a good bite vein where you can see the distal of canine, you can see interproximal regions of premolars, upper maxillary molar. Here, it's not open contacts. Probably you could capture in a next view. So if I see in the next view, I'll say, okay, fine, at least I can see in one view. At least one view, I should be able to see all the contacts to be open. So please make sure that, imagine these are your teeth, patient's teeth. So make sure that this, when you place the receptor, it's parallel, not like this. And 3 things, they have to be parallel, right? 1, teeth, the receptor, and the X-ray beams that are coming, they have to pass through those interproximal regions. So if you see at this projection, they are not straight on. So you will end up getting something like this. So these are not open contacts. They are closed. So you cannot get any information. So how do you rectify that? I think I have. So make sure that the blue, this is how it should be, not like this one. Make sense? So again, that's one problem where you could end up getting a closed contacts. One more instance is like, imagine these are your teeth, okay? And you could place the sensor here or receptor parallel, but if you are not angling the beam like straight on, if the tube head is like this or like this, you could still end up getting the closed contacts.
I have a question.
Yes.
If you are doing the canine view because you have the curves of the mouth, what are you doing it parallel to? Would you place the receptor parallel to like the canine itself? Or
Sometimes, okay, so you have to look into the oral cavity. Sometimes you may have to place it straight on or parallel to the canine. If there is very small, pretty small, then in that instance you cannot place like this, the sensor, because it's going to touch the anterior teeth. In that scenario, what you have to do is, you do end up placing like this, the sensor. Then definitely you'll end up getting closed contacts. But you have to see that did you capture the distal canine in one view, and in next view, did you open the contacts, right? Because we are all different, right? Our mouths are different, teeth are different. So we may have to make some adjustments when you are getting to the images. But the whole idea is, you should know what is ideal. Can we get close to the ideal full mouth series? So if you start cutting the corners from the very beginning, then I showed you some images, that's where we'll end up getting all the full mouth series.
Wait, to follow up on that question, you said you have to make sure you capture the different parts in different views. Do you
Yes.
retake the same one and get open context once in the distal another time, or move on to the next?
Move on to the next one, because most of the time, getting full mouth series is the easiest job. You could finish in 20 minutes. So, to answer to your question, yes, move on, don't just hang up to one particular view or projection. Okay, somebody asked me this question. How do we open the contact on the posterior most tooth, like the molar, especially in this region, right? We think the arch is curving like this in the posterior region. So how do you open contact, right? So you do place the sensor pretty much like that, and they're parallel. And perpendicular to that, you'll release X-rays. If you want to open the contact here, you do make a slight change. As you can see here, this cone is aligned to open the contacts between premolars, whereas this one is aligned so that you can open the contact between first and second molar. So sometimes you may have to make some modifications to obtain what is required for our clinical purposes. Make sense? So cone alignment. So some of you guys who came last week experienced that not many people are familiar with collimator, right? So I would highly, highly recommend that when you go and practice, please ask your dental assistants to use the collimator when you're taking radiographs. because you're going to reduce the surface area and radiation to that patient drastically, almost like 50% reduction in the dose per PA. So when you are trying to align this cone, if you don't align properly, we could end up getting something like this. So remember, I told you, you need to capture the molar, and we don't want to see any white space. This is called as cone cut, basically. Back in days, they used to use only the cone, I guess from the circular one. Since it was cutting like that, they use the term cone cut. Since we are using for collimator, they should have come up with a new term, but we are still sticking to cone cut. So basically, what it is happening here in this case is, imagine these are the full set of teeth, right? So the receptor should capture, and the X-ray should come, we can capture the whole set. What if the collimator is like this? So you are losing that white space, and it's not helpful for us. So please make sure that it is covering the teeth. Otherwise, you're going to miss a lot of information, unnecessary radiation information. Yes.
And in that one, is there too much alveolar bone? You don't
Yes.
need that much, or?
No, we don't.
How far up do you need?
2 millimeters.
Okay, all right.
So why I am hung up on 2 millimeters is there any loss of lamina dura? Is there any pathology that you are seeing there beyond the apex of 2? So when you are using the collimator, it should, when you look through the cone, this is how it should look like. So that means complete capturing. This is a film that you're seeing from the cone. So there's nothing missing. Here, it's to one side. So if you are using something like this, then we are going to get a cone cut. And that's because of the translation, because you are moving. And there is something called as rotation. This collimator, when you are using it, please make sure that for posteriors, you have to place like in a horizontal fashion. It can rotate. So for anteriors, so you have to rotate like vertically. If you don't rotate, still it's like this, and you capture it, you're going to end up getting something like this. So this is called cone cut due to rotation. If you're not familiar with this, don't worry at this point, because anyways, when you come down to the clinic, you're going to use, and you'll come to know what I'm trying to talk. Right? Collimator is basically, imagine this is your collimator. So, if you want to capture the posterior teeth, you should be placing like this. For anteriors, because they are like this, you'll flip the collimator like this, so that you can capture. Make sense? Again, you could, if you're not placing the horizontal angulation, you could end up getting the problem again here is a cone cut. And here is too much of vertical angulation. You're keeping the cone like this, if the teeth are like this. So we talked about the horizontal angulation, vertical angulation, and sometimes if you are not using the proper angulation, especially the vertical angulation, you could make your teeth to look either too long or too small. If it's too long, we call it as elongated, or if it's too small, we call it as foreshortening, like this one. So what is the problem with this? Especially if you're trying to do endodontic treatment on this particular tooth, you don't know the exact measurement, right? What is the length of this root?
Fuzzy? Is it too fuzzy?
No, because the tooth has become smaller. It's because of the change in the angulation.
Oh.
So I have a quick question.
Yes.
If you're doing endo,
Uh-huh.
can't you use, since you've already done endodontic treatment in that tooth in the front, couldn't you use that if it's already in your notes, that you have that length, and use the measuring stick to do a comparison?
Not everybody will be smart like you, Jacob. Yes. Yes, you could.
Okay.
So again, remember, this you're not going to see in our clinic or in the school, general school. This you are going to encounter only if you are using phosphor plates or also called as PSP plates. So it's like pretty much similar to fill. If you are attended any dental practice, you may have seen. Basically, there are three types of sensors or image receptors. One is film, next is PSP plates or phosphor plates. Now what we have is the digital sensors. So with the film, you take, you expose, and then you put it in processor, you'll get the image that you can see on the film. With the PSP plates, it's slightly different. So you take the image, and then you have to put it in a scanner. And then, now the latest scanners, they'll take out the image, latent image that is present on the plate or the film. If you don't erase and take one more image, then you can get double images. Because there was one image already, and on top of that, there is one more image. So now, if you like PSP plates, or if your staff or in the practice that you are going to go, you're using PSP plates, please make sure that the scanner will erase the image before you capture. Not so much with our direct digital sensors, we are going to see, but if you're using a film is like pretty much like this one, so you can mold it and you can place in the patient's mouth. It's a little flexible, basically. So when you place something like this in the patient's mouth, this bending portion can cause elongation of the tooth. With the digital sensors, because it's like a rock, solid rock, keeping in the patient's mouth, you cannot bend. So we are not going to see this, but you may encounter if you are going to use film or PSP plates. Yes?
Those are the same, or the same teeth, right? It's
Yes.
just- Okay.
Yeah, you can see the difference.
Yeah.
That one is elongated, this one is not. So now, what are the forms that we use in the clinic? So this is the form that you're supposed to use when you submit your competency. So before you submit a competency, there is something called as experience. You can do n number of experiences, doesn't matter to us. Competency, at least one experience, and then you do your competency. Full mouth series. You should be able to demonstrate that you can take good set of full mouth series using the criteria that we discussed. When you submit, please use this sheet. So basically here, how many number of retakes that you took. Remember, this I'm talking about clinic. Now, since you are in D1, I don't care how many number of retakes that you take. I don't care at all. Because you're taking the images on the skull. You're trying to get to the perfection, how we can get a good set of full mouth series. Once you know that, then when you're acquiring these images on the patient, there is a limitation. So we know that 14 plus 4 is 18 radiographs that is constituted as full mouth series at this particular time. So you are allowed to take 5 more retakes. So that means 23 radiographs is the max. And say for instance, if you take 24 and you submit this as a competency, what I do is look at the 24 number and say you're failed. I will not look at the, even you could have done the best full mouth series because you did not fulfill the protocol of not maintaining the retakes. Okay. Max 5. And for bite wings, max 2. That means if you're taking a full mouth series, you could take, sometimes, let me give you a scenario. A patient who is relatively young, like maybe 18, 20 years of age, no high risk caries, no periodontal. After you check and you obtain only the bite wings and a panoramic radio. In that scenario, you are allowed to take bite wings because 4 plus 2 more retakes. Make sense? And what is the criteria that I look? Is this one. These forms are available on your clinical manual. If you don't find on the clinical manual, or if you're having hard time to find, then we do have the hard copies in our clinic. Okay. Okay, let's review some examples here. Let's start from my favorite side, that side. Yeah. What's your name?
Me?
Yeah.
Sandipta.
Sandipta. Is that correct? Or did I butcher your name?
No, that's right.
Okay. So can you comment a little bit about our image quality analysis?
I think for a lot of them, the Uzo is in parallel to the top of it.
Okay. So my suggestion would be is when you are looking at the radiographs is to start from one side, like for instance like this one to number 1 and go all the way to 16 and then 17 to 32 and then the bitings. Does it make sense? Like this one. I'm not going to write on this one, so basically and then so how about this one? Let's concentrate only on this particular view. If you are going to be late, blame Sandipta because he is delaying. Great, okay?
Not sure.
Nothing? Yes.
There's too much noise.
Too much of noise. Okay. Yes.
They're also missing part of the crown, but the conditions are kind of difficult to get that, because it looks like they're missing all the teeth on the upper. So really, it's not even a necessary observation.
So I'll answer your question. Okay, going back to your suggestion that the image is noisy. Do you think it's really noisy?
Well, I guess not. There.
That's the best image.
Is it right?
Yes. You should have seen the images before I came to this telescope. I mean, when it started working. Okay. Clue is look at her 2013 images and compare with this. Anyways, not going into the details, let's look at this view. Next. Next to Sandipta. Yes.
Same picture?
What's your name?
Mohammed,
Muhammad.
there's no open contact.
Okay.
Also,
When
the
you
two-
say open contacts, you are referring to which two? I think I'm the dumbest person in this whole class. I don't know which tooth you are talking. Can you enlighten me a little more?
premolar and a
Anybody who's got laser, pointer? Maybe you should bring a laser so that when I ask, you can just point. Yeah.
Oh, I was gonna say it's 5 and 6 that have lack of contact, but the big problem is that he's missing the apex, and the patient didn't bite down all the way on the thing. You can tell because the bar is not even touching the teeth.
Okay. Good. How about this one? Next to Mohammed.
Julio.
I'm not familiar with your name. Can you please repeat it one more time?
Julio?
Julio.
Yes, sir.
Okay. If I'm butchering your name, sorry. I'll try to get to your names as close as possible.
This one, the angulation, there's like there's not an open contact, but you have a good open contact between the central incisor and the lateral incisor.
How many of you agree with that particular statement? Or how many disagree?
Yes.
How many agree that there is no contact? How many disagree? So remember, in this view, you want to see only the contact to be open between this and this, not this and this, because that's why you want to capture the distal of canine in this particular view, because there is a curvature. You can never ever open a contact in that particular view, unless there is a diastema or something. Okay. How about this? What do you think is this one? I'm going to ask a female student here. What is that? Any volunteers? Yes. What's your
Piercing.
name?
Mallory.
Mallory. Okay.
It's a piercing.
No strain. See, no strain. So what is happening here? How about this one? What is the problem with this? Can you speak a little louder so that
The
I can
tube-
save some energy?
Either the tube wasn't aligned or it slipped, so the tube is now down, which is what's causing that white spot in the upper right.
So basically there is a cone cut. But you do see that tooth number 8 and 9, you are seeing the good open contact. Okay, that's a good image. How about the next one? What's your name?
D'Angelo?
D'Angelo, yes. You were there last week, yes, in my lab, yeah. Yes,
It has those white spots too. I don't remember.
those white
why.
spots, oh my God. Okay.
It has
We
those-
are not there yet at the looking at the white spots. So let's concentrate on only the images. Like, do we see the apex? Do we see the whole tooth?
I see the whole tooth. I see the apex. It has open contact. I don't know what's wrong with it.
Oh my God, you started diagnosing it. Diagnosis comes at a later point. Okay.
Okay.
By the way, I just saw a movie by name Are We There Yet sometime last week. So we are not there yet to diagnose. So first we are to just look at the images. Are they a good diagnostic or not? That's all our job. So that looks pretty good because you want to see 10 and 11 open contacts. That's all your goal. Yes, we do see that. And there is a cone cut. right? How about this one? What could have happened? Basically, the sensor has flipped like this, right? It's moved. It's not parallel to the occlusal plane. How about this one?
They were balancing it on one too, so it was hard to get the actual image.
Okay.
On that one, by the way, is it appropriate, I don't know how the sensors work with this, to have the patient actually go and hold the sensor in place while you're taking that? Because I know with some of the thicker phosphorus plates, you can have the patient actually hold it in place while you're taking the X-ray.
I'm going to ask you that question. Okay, whatever you just mentioned, maybe if our time permits, we will be able to cover that topic called as radiation safety protocol. I'm going to grill you on that, okay? So now, can the patient hold the sensor? The answer is absolutely no. If I see somebody doing that, he'll be kicked out of the clinic. Okay? How about this one? Is it a good radiograph? In that view, you are supposed to capture what are the things? Molar view. First molar, second molar, third molar, right? In this case, the second and third molar, it looks like they are missing. Right? Because I don't see any tooth here. I would imagine. For that particular instance, yes, this is pretty good view because you can see 2 millimeters beyond the apex. You can see there's something in pathology. How about this one?
Missing apex and open
Yes.
contact.
How about this one? We'll go to there. Yeah, Angelo, next to you. It's nobody. Yeah.
Yeah, it looks pretty good. The open contact.
No, your name, please.
Oh,
First.
Dave.
Dave. Okay.
You can see the crown, you can see the apex, you can see the open contact.
Okay. How about the next one? Next to Dave.
Dom,
Tom.
D-O-M,
Okay.
Dominic. I don't know, I think it looks pretty good. Are you
Okay.
talking about the middle ones?
Yes. This
Yeah.
one. We are talking about this one. Yes. This is pretty good. This is pretty good.
Yeah.
Okay. How about this one? Next to Dom.
Darby,
Darby. Okay.
I think it also looks pretty good. I mean, there's not open contacts on the inside of it, but it's in the one over, so canine. I guess maybe more of the apex in this.
Yeah, apex, like one of the criteria that we look in periapical radiography, are we capturing the apex or not? In this case, absolutely no, we are not able to capture. So the patient did not bite, so we are capturing more of superiorly. Yes, the open context, yes, definitely I do agree that, no, just you, yes, this is right. You need to see the open contact between lateral incisor and canine. You're right, there is definitely open contact. How about this one? Sam? Sam?
Yeah.
Yeah.
They can't see it too well.
That's a very good reason. That's a very, very excellent reason. So I'll help you out here, okay?
Can you see the,
So the apex is missing.
yeah,
And we have to capture the distal of canine, right? So we captured the distal of canine, right? and the open contact, but you are missing the apices here. Here, you're missing the occlusal portion of the tooth. Okay. Do you think we can, yes?
Did they also slice it a little bit so it looks like the annulation's
Yes.
a little off?
We'll review one more example, and then we'll take a 1 minute break. Yes.
Back with like the other example, when like the molars are missing, do you still want to like start it like more like posteriorly, or like, because you know like in that last picture it still kind of showed part of like, I think it was like the premolar. Do you want to start it like more like where that first molar like starts, with like just like space, or just kind of focus right on the first molar? Do you know what I'm saying? Like should you just center it on the tooth, or should you show like the open spaces?
Just follow the protocol like for molar view. You have to place the bite block on the second molar.
Even if there is no second molar?
If there is missing molar, then there is always exceptions are there, right?
Okay.
So we could see if there is any missing tooth or root remnants on the panoramic radiogram.
Yeah.
So depending on the situation, we may or we may not require, depending on the clinical situation.
Do
Yes.
you ever like place the bite block like on the gum, or do you always have to place it like on a tooth?
So we'll try to place on the tooth, and if there is alveolar ridge only, there are no teeth, then we don't have any other choice.
Gotcha.
Yes.
I was gonna ask where you place it if you're missing teeth.
Yes, so we could use cotton roll to support, because on the alveolar ridge, it's really hard to stabilize the bite block. So you use cotton roll to stabilize. You place the cotton roll and place the bite block as the patient falls. Okay. So what do you think? You guys need a break, or should I go over this case? Break. Break. 1 minute. Your time starts now. 8:58. We'll reconvene at 8:59. Okay, so there, yes.
I just figured out what that.
Your name, please. Steve. Okay. How about this one? You have 30 seconds because we have to move on.
Looks like there's, the occlusal surface is kind of cut off. Oh, the one on the right? Oh, the apex is shot.
Yeah, the apex is missing right here. And of course, the part of tooth is missing. How about here? You're able to see a little bit of
That's
tooth,
what I
but
thought,
it's
yeah.
still here. You're missing the occlusal area.
Yeah.
How about this one? The next one.
Stanward. I wouldn't say I'd say it's pretty okay. We can see the contacts. You can see the full tooth.
How about next to time over?
Becky, it's like, I think the contacts aren't as open as you want them to be. Other than that,
Why do you think that's?
I don't know. You just have to do it again.
Horizontal angulation, right?
Okay.
Yeah. How about this one? Next to Becky.
Buniel.
Can you make my life a little easier?
Oh, Buniel.
Buniel.
Yes.
Close?
Yes.
Okay. Buniel. How about this one?
It looks good. There's open contact and you see the apex of each teeth.
Huh? What are the teeth that you want to capture in this?
The incisors and part of the canine.
Which incisor? There are 4 incisors.
The 25 to
It's called as lateral incisor view. So that means we need to capture.
the lateral incisor.
And next to that is canine. Yes. How about this one? me now, right?
Yes. There's no apex.
Okay. How do you rectify this?
So the sensor, we readjust the sensor.
How do you adjust the sensor?
Pull it a bit more down
Okay.
to cover all the tooth structure.
Okay. How about this one?
Madeline,
Madeline, yes.
um,
You helped us last week.
yeah. This one's also missing the apex. and
Louder, please. I
You
can't hear.
also can't see the apex in this one. And you will probably open up the contacts in between the molars.
Okay. Good.
On that, is there any particular reason you're not wearing the rubber denture for the X-rays? To push the sensor down?
Is there a reason that the patient is not wearing a denture to obtain?
I mean, unless they don't have it, which. If there's no metal, it shouldn't.
Oh, that's gone way beyond. So generally, I don't advise anybody putting the denture and taking the radiographs because for a novice dentist or novice dental assistant, they could go crazy looking at those images, one. And we thought those dentures only is helpful for our diagnostic purposes. You don't want any artifacts. For instance, like nose ring, right? So less is better in this case. So, yes. We'll start from this. So you have like 15 seconds.
I'm missing the apexes.
Yes. Missing apices.
We're missing the second molar. Looks like.
Okay.
That. And all I got.
So in that particular view, what are the teeth that you need to capture? Right? So we are able to see even the canine. So that means the sensor is way anteriorly positioned. So the sensor should go posterior. And of course, the things that you mentioned. Yes.
My name's Austin. This one, the angulation's kind of tilted.
Mm-hmm.
We're missing a few apices, and I think we see a few too many anterior teeth in this view.
Okay. It's good.
My name's Libby. You don't.
Libby.
Yeah.
Okay.
You don't get a lot of the canine, and the contact isn't really open between the canine and the lateral.
This student actually likes more anterior placement, right? For everything, it's much more anterior. So here, we are supposed to capture only the lateral incisor and canine view. It's again, much more anterior. Sky capture, even the central. Moving on, the next one.
We have too much of the apex visible, and we're missing the crown of 8 and 9.
Yes, so 8 is also missing. We should be able to capture the whole of 8 too.
And the intestinal.
Yeah. Placement issues, right? Next.
I'm Keith.
Keith.
Yeah.
Okay. Like Keith Urban? Yeah. I like his song, so that's why.
It's a little angled and there's no open contact between the lateral and the canine.
Okay. Next.
Blaine. The cuts off the apex.
Yes. But you got the distal canine.
Yeah.
Beautifully, right? But apex has been shot off, yes. Next.
Abdul. And
How many of you agree with Abdul's statement?
What are we on?
Yes, oh, okay, so this one, okay. You're looking at this view. Oops. Yes, you're right, Abdul, I do agree with you. Okay, next, moving on. Where did I stop? Okay, yes.
My name is Wen. Wen.
W-E-N.
Yes.
Okay.
Which picture we are looking at now?
Good, good question, here.
Okay. I think to anterior, and I only see the first molar, didn't see the other molars.
Yes, we need to capture the second molar, at least second molar, right?
Yeah.
So you do see here, okay, that's fine, and we do see molar, that's also fine. Premolars, but I do see here, right? So this is clinically acceptable, again, remember. Ideally, no, this is not ideal. Okay. So when you submit for D1, I would expect close to ideal. Okay. How about this one? Louder, louder, please. I can't hear you. You guys make me feel that I have to go and see ENT person. No, you have to speak a little louder.
My name is Shuchi. I think this picture looks fine. We can see the apex and also the contact.
So what are the things that you want to see in this image? This left canine, do you see that? No, right? So it's important that you have to capture the distal canine. Okay. Moving on here. How about this one?
Heather?
Heather.
Uh-huh.
You were sitting there last week.
Yeah, I was.
Okay.
I don't know what happened to that white quad on the apex. Is that normal?
Oh, this one?
Yeah. Is it normal?
Well, yes and no answer. So it's called as mandibular tori. There is extra bone that is present.
So it is normal. Yeah. I think, yeah, it has open to contact, right? And then we can see.
So we are looking at this view, right?
Uh-huh.
So you are talking about open contacts, okay. In this view, what is this view called? Let me ask you that question.
Not the lateral. Oh, the lateral incisor.
View, so that means you need to capture?
The lateral incisor.
You see that? A smidge, part of it, right?
Yeah.
So basically, it's a posterior. So the white block should be placed between lateral incisor and canine so that you can capture this and that. How about this one? Next.
Ashna, I feel like the contacts are okay, but the overall, I feel like it's not ideal.
Why do you think it's not ideal? What makes you think?
It could use some more contact. Open contact.
So can you help me to understand, when you say open contact, so which tooth are you referring to?
The central incisors.
These two? This is lateral and this is canine, right?
Mm-hmm.
What if the patient has malocclusion? Like in this case. Oh, I gave you the answer. Okay, so the patient has malocclusion in this case, so that's why you're not able to open the contacts.
Okay.
You should be centered on the.
How about the next one?
Mallory. Well, you're not really capturing the whole crown of the tooth, so you can't see the two centrals, and also the contact. Even though there's malocclusion, you still are getting overlap. I was on the other one. Yeah. Yeah.
One thing that you forgot to mention is, or you missed, is it's a lateral incisor. We want to focus again on the lateral and canine. So if you place the white block between those two, you'll get it. That's it. Again, placement is very, very, very important. How about this one?
I'm Chrissy. It's too
Chrissy.
see.
Okay.
It's too posterior. You're missing part of the. You're missing the distal part of the canine, and
What else has happened in this view?
it's on an angle.
Okay. What else has happened other than that?
Sure, is a ridge somehow.
Yes. What do you call it as? We just learned. Yes, foreshortening. Yes. So there is a change in the vertical angulation. So you made this person made the tooth look like pretty small. Foreshortening. Yeah. Yes.
McKenna,
Uh-huh.
the second molar is cut off.
Yes. Good. And also the apices, right? How about the next one? Okay. Fast.
It might be too anterior considering you're supposed to
Wait. This is the next. We're talking about the top one, right?
Yes.
Okay. It's too anterior.
It might also be too far incisal, considering how close the apex is to the edge of the frame.
I think that looks good to me. Okay, next.
So the occlusals.
Your name, please.
Oh, Bethany. The occlusals are not parallel.
Okay.
Like it's on an angle. Also, some of the occlusals are cut off, and the second molar is largely cut off, and you're missing.
Wait. I'm lost now. I'm lost. We're looking at that, the second image, right?
Yeah.
Okay, go ahead.
And then you cut off part of the canine as well.
Okay. So one, we did capture the distal canine a little bit, but there's still little overlap. The overlap that you're seeing is only with the enamel. That's acceptable. If it's more than that, it's not acceptable. Make sense? Because enamel you can see through and through. If there is a dental caries or not. If it's with dental overlap, it's not ideal. Okay. Next one. Now, Bethany. Okay, here. Come on.
So the image is too angulated.
Yes, I have to literally see like this if I want to diagnose. Right?
And the open contact is, there's very little open contact, I don't know if that's considered.
So let me ask you this question. In that particular view, what teeth are you supposed to capture?
Lateral?
Do you say lateral incisor? She's also looking like me, like this. Yeah. So please make sure that you take good images so that I don't have to bend and see and diagnose, okay, every time. So imagine 70 students into 4 times, right? 300 students plus, and grads. Imagine if everybody takes like this. What happens to my back? Okay, that's a lateral incisor view. Again, remember, they did not place the white block between lateral and canine. In spite of telling repeatedly, and if I see these images, don't you think I should freak out? And they submit this for competency. So that's why I'm telling you, please do not submit similar crappy images. Next.
It's missing one of the lateral.
Louder, please.
It's missing one of the lateral incisors, so the sensor should be placed on the incisor of the two central incisors.
I was hardly able to hear. Did you guys hear? Okay, then fine. Move on. Thanks.
The image is too angulated, it's not parallel to the occlusal plane.
Yes. And next one. Megna.
I can't see the crowns on this image. Also, I don't think they even have the right T. They're supposed to have the distal of the canine, but I see molars.
Matt, that's way too far apical, so it cut out the crown.
You guys did not have breakfast, or is it you guys talk very low, or in my class you guys are talking very low, so that I can't hear anything.
It's too far apical, so the crown got cut off.
Ha! That's very good.
The lateral incisor contact with the canine is not open, and you're missing a little bit of the surface, the occlusal surface of the lateral incisor.
So, if you look, or you may have observed that the problems, most of the problems are in this region, right? Lateral incisor region. The ones that I explained. So try not to repeat those mistakes. Moving on.
There's no
Your name, please. Well, maybe next time. Okay. Okay.
It's fine. There's no contact with
Okay.
open contact. And also,
What happened there? Can you open contacts there? Or the patient is having malocclusion?
Lisha, so the sensor, there's no open contact between the lateral, actually there is, between the lateral and the
So this is lateral, right? Canine. No,
This
this is lateral and
yes.
canine, yes.
So there is the open contact between the lateral and the canine.
Yes.
So I think this is okay.
So basically the sensor is flipping. But this view.
the occlusal on the crown of the canine, the first premolar is missing, and also it seems like it's tilted or might be malocclusion in the second premolar region. Oh. I was looking at the image.
You think it's still, there is malocclusion?
No, I was looking at the bottom.
Yes.
Sorry.
No, no, no. You said malocclusion, so I'm trying to rectify you that there is no
Okay.
malocclusion.
Okay, okay.
What else has happened here? What is the term that you use if you make the teeth look smaller? Yes. Yeah. How about this one? Yes. What's your name?
Stella. Stella.
Stella. Okay. That's easy. Okay.
There's an artifact on the top of the image.
What do you call that artifact as? We use cone to take X-rays, and if there is a cut, what do you call it as? Okay. That's exactly what it is. Okay. Moving on. Okay.
So, I think bottom?
Yeah.
Right. There's no open contact with molars. And also the apex is like visible in the maxillary molars and also mandibular.
So is that a good thing or not a good thing? In white wings, we generally don't expect to see the apices. Right? You want to capture only the occlusal portion of the teeth because that's where you want to diagnose the interproximal caries. Okay, moving on.
And Bonnie, it's great.
Right? Agreed.
Looks like the contact between the molars is not all the way, or it might be not all the way. Seems like
Wait.
Are you on the light wing? The third
Yeah,
one?
this one.
Yeah. Looks like the last one was.
Well, hold on to that. Remember I told you, are we there yet? The answer is no. So,
I think it's okay for the 5 minutes.
okay. How about this one?
It looks fine.
Looks fine? Okay, if you say so, I do agree. Questions with this particular? Oh my God, we spent 2 hours for this? Yeah.
How do we know when we're supposed to capture the apex and when not? Because some of those it has it, some of them doesn't. But
So remember, for white wings, we don't capture apices because you want to see only the interproximal areas. That's it. For all PAs, periapical radiographs, so that's where you need to capture the apices. Any questions with that? Yes?
Is it possible to get an open contact on someone with malocclusion?
Well, it depends on what kind of malocclusion you're talking about.
Let's give the example of the mandibular central incisors.
Okay. Oh, yeah, I'm supposed to cover this one, right? Radiation biology. Yes, if sometimes the answer is yes. You could see clinically can I open contact or not. So remember, you have to check always first clinically, then order radiographs. Then you come to know, okay, can I open contact or not? Yes, that's the judgment call that you make when you see the patient. Do you remember where I stopped?
Slide 22.
Slide 22. Okay, so okay. Oh, this one I think. Right? Yes. So we know completely a different, right? We talked something different. Now we are going into mitosis, radiation biology, 2 completely different things. So please remember, this is a very, very important slide for your boards. Okay? So near mitosis, the cells are more sensitive to radiation. Late S phase is not. Probably you could expect a question on your midterm or maybe your final, I don't know. So what is going to happen? So generally, if a cell is hit with the radiation, repair could happen within hours, or it could take like days or months. Or there could be a genetic alteration, or within the same person, it could take some time to develop a cancer. So generally with a low dose, the things that could happen are like cell mutation, cancer, and in utero effects. With the high doses, there could be cell killing directly, okay? Because it's a very, very, very high dose. So this is a cell killing in the dental radiograph is pretty much negligible because the amount of dose that we use is 3 milligrams. Anybody got a chance to look at Gray's, Sievert's, REM, Becquerel units? Nobody, okay, wonderful, okay. Please look, okay. What do I mean by stochastic effects or deterministic effects? Okay, there are two types when a radiation hits the body. How do you determine what are the effects it's going to cause? Okay, stochastic effects. Basically, it means all or none. The other one is deterministic effects. It means it is proportional to the dose that the patient is getting. So, for example, if on one first day the patient gets 10 rays of radiation, and third day 20, so you have to accumulate depending on how much the patient is getting a dose. There could have a cumulative effect on that. So that's called as deterministic effects. Stochastic effects means all or none. So here we say that even one single photon could cause a cancer or some problem to the body. Okay. So most of our principles are based on all or none principle, and here, as I mentioned earlier, there is no threshold. Even one single photon could cause. Here this is proportional to the dose. Examples for this stochastic effect is cancer. So that's why, even with the dental radiology, why we say that you have to be ultra cautious is that one photon could induce a cancer. Although we know that the dose is low, 3 milligray, but still you have to follow the protocol principles. Okay. And some examples. This is very, very, very important slide. Okay. Deterministic effects. It could cause like in utero birth defects, cataracts, and radiation burn of the skin. So, Jacob, you mentioned that you'd ask the patient to hold the film. It could cause radiation burn. So that's why we don't recommend that. So now, deterministic effects we are not going to see with dental radiographs. Very rare, or almost like next to impossible. Because the dose is such a low amount. So, mutation is basically, it means that there is a change in the genetic material that's passed on to progeny. So, ionizing radiation is considered as a very low mutant. So that's why we have to be careful and make sure that we use appropriate precautions. So germ cell mutations, there was a study that was done after Hiroshima, Nagasaki. Some of these survivors, atomic bomb survivors, that they followed through their lifetime. They did not see any increase in the cancer amounts. So somatic, basically it's one individual. If a person is exposed to radiation, they could get a cancer. It may not be transferred to the progeny. It is a somatic cell. Whereas in germ cell, it will be transferred to the progeny. That's the difference between somatic and, and germ cell mutation. So basically, when you look at the radiation, what is going to happen is body is full of water content, right? So it's going to react with the water content, and it could form as hydrogen peroxide, like H2O2, or it could break down into hydroxide or OH ions, and then they could in turn form H2O2 and could cause a damage to the body. That's the mechanism. So now, there is a law that says that what are the cells that are sensitive? Law of Burgoni and Tribondy. These are French people that they came up with, and they suggested that these cells are much more sensitive to radiation, those that they have very high mitotic rate, undergo many future mitosis, and are very primitive in differentiation. Exceptions are small oocytes and lymphocytes. Again, very important slide. What are the other cells that are sensitive? Bone marrow, the cells that are coming from bone marrow. So when somebody is exposed to very, very high radiation, it's going to affect the blood cells or bone marrow. From cells coming from bone marrow will be affected like WBC, RBC, and patients could die like within 1 to 2 days. And least sensitive are nerve cells because they are differentiated and they are non-proliferating type. So LED is the amount that we use to check how much of radiation damage or what kind of radiation damage is being caused. We use that LED term. So dental x-rays, they have very low LED. Alpha particles, they have very high LED. So that means they cause a lot more damage compared to x-rays in general. I'm not sure whether I discussed with you the Russian story that in British coffee shops got killed, the polonium, yes. Alpha particles. Yes, that's, so alpha particles are very lethal. So when you compare with the low LED versus high LED, generally with the X-rays, what we are going to see is one single-stranded DNA damage, whereas with the high LED, double-stranded DNA, there will be damage. Okay? So if you see or encounter a double-stranded DNA damage, so that's very lethal. Single-stranded, most of the times the body tries to recover or repair itself. So whatever the numbers that I am trying to give is from these number of studies that they have done. So they learned from various studies like cancer from the radiologists because they will be dealing with a lot of radiation. They said, okay, it could cause some kind of damage. Okay? And bone tumors in radium dial painters. Anybody is aware of that? Radium, yes.
They were using generally young females, and they would dip the radium on their tongues, and then they would paint that way, and essentially their bones just shattered.
So there was a company that was making radium dials in New Jersey. So they were told at the time that to make a letter 2, like a 12, they have to dip the brush, paint brush, on their tongue, and then they have to paint so that the brush will give the nice 2. So during that process, they swallowed a lot of radium. Radium is nothing but polonium, and they ended up getting cancer. So we know that there are some effects from radiation. And the most famous one is Hiroshima and Nagasaki. And Marshall Islands, we are not going to go into the details, but this is kind of to get a sense that there was studies that was done, and we can tell that some effects are there, like 100 gray, for example, death in 1 or 2 days. It's called a cerebrovascular syndrome. So if somebody is exposed to 100 grays of radiation, they could die just in 2 days. Because it's going to increase the blood vessel permeability, everything there will be leakage. So there is something called as GI syndrome. So if somebody is exposed to temp,
Wait,
yes.
on the last slide, is it supposed to increase permeability?
Yes, it is going to increase, decrease the permeability.
Decrease.
Yes, sorry. You're right. Decrease the permeability. And then 10 gray. If you're exposed to 10 gray of radiation, it's going to damage the villi. You may have learned the villi in your biology class, right? Where do you see villi? Large intestine, small intestine? What is the job of villi? What the hell is talking, right? They will help in absorption. So they will damage those villi. And then, since there is no absorption, people will die within 5 to 10 years. If 2 to 5 days, people could die in 3 weeks. It's called as hemophagocytic syndrome. So here, the blood vessels are affected, like bone marrow, like white blood cells, red blood cells, lymphocytes. Guys, you must be knowing about this. 30 people died in Chernobyl, right? So how many people died as a result of earthquake and tsunami in Japan? Very recently.
8,000.
How many died from the radiation? Why? So if you use appropriate precautions, you could reduce the damage. So they closed or put a concrete wall so that the radiation will not be transferred. So in the next following lecture, we are going to talk about some of the principles or safety protocols that we could use. Okay. 2 grays, it could cause transient erythema. So there was an assistant technician, basically, first time on her job. She was put on the CT scanner. She was pressing the button, and the radiation was releasing. She didn't realize that the sound, and she got sued. That's a different story. So please make sure, don't keep on pressing the button. Okay? When you press the button, radiation will be released. Okay, if you have doubt, please get the patient out and check with some other protocols that are in place. Say for instance, in our dental radiology, you could take a film, put a key, and expose it to see whether the radiation is coming or not. Okay, that's the easiest. Not pressing the button 100 times. Yes?
This person died or not? Because.
So again, depending on the dose.
Yeah, because if it was 6 grays.
Yeah, yes, if you are exposed to 6 grays, yes, patient will die. Fortunately, that patient did not die, but there is a chance of erythema developed. Yes. So, somebody is exposed to 10 grays, that could cause a dry desquamation, so that means epithelial cells will be gone. So 3 grays, there will be loss of hair, right? If you've read about the Russian story, spy story, right, recently, the first thing that after he got admitted into the hospital, he lost a lot of hair because he was exposed to polonium and again alpha particles. And could develop cataract with the 2 grays. So the things that you have to be careful when you're dealing with radiation are like age. Generally, younger generation, they are more sensitive to the radiation. So you have to use appropriate protocol. For instance, in our dental radiology, you are supposed to put thyroid collar if you are taking radiographs in children. Okay. Gender, females are generally susceptible to radiation. And depending on the radiation dose and rate, you have to use appropriate precautions. For example, like as I told you guys, you could use for alpha particles just a sheet of paper, right? Block. For gamma, you have to use 1 meter of concrete. So for us, we'll learn in next week's class. So now, what we know about cancer? Somebody has to keep a tab on time, 9:52. Okay? So what we know? So whatever we know is from the very high sources of LED, meaning to say like atomic bomb. Okay. And then what they said was, okay, for instance, we have the information from very high dose. Can we take that information and take it to drum down or drill down to the dental radiation? Can it cause something? So, do we know something related to dental? The answer is absolutely no. We don't know anything about low doses because we don't have any studies that suggest that they could cause cancer. Whatever the information is, we have is from the very high doses. So, this slide basically tells about the gender and age, how they are sensitive. So, in this particular example, like 10-year-old female person is 6 times more likely to develop a fatal cancer when you compare with a 50-year male person. Okay. 20-year, they are likely to develop 4 times more. 30-year, it's 3.5 times more likely to develop a cancer. So the bottom line is age and females are more susceptible to the radiation. So there was a lot of studies that they did, like on Drosophila, which I'm not going to go into the details. Okay? But to give you a little bit of information that they have done some scientific studies and they said it could cause some defects. For instance, the most one or the most concerning thing is about the embryos, right? Let's focus on the fetal doses. Okay. So, if a patient comes to you and says that she is pregnant, do you get a radiograph or not?
Put a lead apron on? Does that help?
Depends on the trimester.
It depends on the trimester 1, okay. You said a lead apron. Anything else?
I would think it would depend also the procedure, like, I don't know.
No, we are just talking about dental, so forget about all other things. Just let's focus because we got the information from there, now we are drumming down to dental.
It also depends on when the last radiographs were taken. So if they're a new patient and you're establishing a new patient, then obviously you're gonna wanna have a higher, or you want x-rays more than if it's a 6-month recall.
Okay. So, to answer to your question, so there is absolutely no risk to the fetus with the dental radiology or dental radiography. Okay. So the bottom line is, if the patient is pregnant, there is absolutely no contraindication for dental radiography. Okay. One thing, as you mentioned, yes, we could take appropriate precautions. If they're really concerned, you could put a lead apron and then get an picture. If the patient is, for instance, does not want to get a radiograph, that's also fine because you have to respect their thing as well. So we know that scientifically there is absolutely no contraindication. This is not what I'm saying. It's approved by ADA, FDA, American Pregnancy Association, yes.
I was going to say, that being said, are there any laws in any of the states that prohibit x-rays for pregnant women?
No.
Is there a citation?
Yes.
Like a direct one?
Yes.
Do you have it on you by any chance?
I believe I
Just like-
updated last night, well,
Just for having it in my back
The
pocket.
ADA
in case
website
you have
has
a
it on.
yes, somewhere it is there. Maybe in radiation safety protocol or something, somewhere it's there.
On the ADA website, it has it.
Yes, on the ADA website, yes. Even in my PowerPoints, there are 3 links actually. You could go into it. So, before you obtain a radiograph, always assess what are the risks, and then assess, is it beneficial? Should I take a PA? Should I take a biplane? Should I take a CBCT scan? Should I take a CT scan? Then, do you need more information? So always you have to take benefit, risk, and then weigh what is beneficial to the patient. So, this is very, very, very important slide for your information or knowledge. So we use something called as background radiation as our guideline. What exactly do I mean by background radiation? Background radiation is, since we are born in this world, we are exposed to different varieties of radiation. For instance, if you are flying an aeroplane, you could be exposed to cosmic radiation, right? So we use that as our guideline, our baseline, and compare with the imaging modalities that we are okay. For instance, here in the panoramic radiograph, the very first line here, it says it's equivalent to 1.7 days of background radiation. So you can say that it's like an extra 2 days of living in this world. That's the equivalent dose that the patient will get if you order a panoramic radiograph. So remember, I told you, don't try to use these spade films. There are some older dentists, they love these spade films. But as younger generation, like you guys love Apple, right? Most of them. Products, right? iPhones, Mac, whatnot. We have evolved from Microsoft, right? Nothing against Microsoft, but they are also good products. Something similarly, as we evolve, there are some advantages to the patient. So don't use D-speed film, use collimator, use direct digital sensors so that, time, I was wrong, okay. Okay guys, to be continued.